Hi, everyone, and welcome to another episode of Dr. Gilbert Hosts. Today, we're going to be discussing the mental health challenges of Parkinson's disease, and that includes anxiety, depression, apathy, impulse control disorders, behavioral and personality changes, hallucinations, delusions, the whole gamut of problems that people sometimes experience with Parkinson's disease. I get so many questions about this, so I'm really excited about our topic to help us answer some of those questions. And our guest today is Dr. Mark Groves. He's an expert on treating these issues. So I am very pleased that he's here with us today to share his knowledge and help us get to the bottom of some of these really vexing issues. Now, it is my pleasure to introduce Dr. Groves to you. Dr. Mark Groves is a psychiatrist who specializes in the psychiatric management of Parkinson's disease and other movement disorders. Until recently, he was an assistant clinical professor of psychiatry and neurology at the Icahn School of Medicine at Mount Sinai, New York City, and now he maintains a private practice in New York City. Dr. Groves is a graduate of Brown University, and he attended medical school at the University of California, San Francisco. He completed his residency in psychiatry and a fellowship in consultation liaison psychiatry at Columbia University, New York State Psychiatric Institute, and he is board certified in psychiatry with subspecialty certifications in psychosomatic medicine and neuropsychiatry, behavioral neurology. Welcome, Dr. Groves, to our program.
Thanks, Dr. Gilbert, and also thanks to the APDA for inviting me to speak today. I'm very excited to talk about all of these topics.
So Mark, would you start us off with a brief introduction, and then we'll get to our Q&A. So take it away.
Great. So the challenge for me with so many topics that I'd love to share with you was to reduce it down and to try to be brief enough so that there's a lot of time for questions. We're going to cover 6 specific topics. I'm going to start with themes of psychotherapeutic support and counseling, because I want to emphasize that psychotherapy can be a very, very important piece of the support for mental health challenges in Parkinson's. Then we'll cover depression, anxiety, apathy, psychotic symptoms, and impulse control disorders. I'm just going to begin with some quick disclosures. And I have no conflicts of interest to report. Many of the medication treatments that I may discuss in the talk are off-label uses, which means that they're not specific indications approved by the FDA. As a neuropsychiatrist, it's not uncommon for us to prescribe meds for conditions without them being directly approved for that indication. So first, we're going to talk about common themes of psychotherapeutic support. I can't emphasize enough how non-medication approaches of psychotherapy and counseling, whether individual treatment or group or support groups in helping individuals with Parkinson's live well with their illnesses, I can't emphasize enough how important that is. In the slides to follow, I'm going to highlight a small number of common themes and areas of focus that I've heard over the last 2 decades in my privileged immersion in individuals with Parkinson's and their experience across the course of illness. The experience of the initial diagnosis is very, very important to explore and support with many individuals. Unfortunately, understandably, not uncommonly, it's a shock. And unfortunately, sometimes the diagnosis is delivered in an inadequately supportive manner. I've even had a handful of patients over the years who've gotten the diagnosis upon meeting the neurologist in the waiting room before they even have the opportunity to develop a rapport and be examined. And so I want to emphasize the acceptance as a process, the acceptance of diagnosis, because people vary always, and that's what's so interesting as a psychiatrist and working in this area, in how able they are to accept the diagnosis and their own internal coping strategies of gradually allowing the full implications of the illness to be absorbed, depending on their personality style and many other variables. And so there's a lot of opportunity to support people through that process, which can continue for even years. Another very common area of focus that I enjoy talking with people about that I find high yield is dilemmas over disclosure. People often don't want to be treated differently, and they'll hesitate to share their diagnosis with others. Certainly in certain workplace environments, when there aren't overt symptoms, that often can be a necessary strategy. But often I'm more frequently put in the situation in which I'm encouraging people to disclose their diagnoses so that they don't have that psychological distance from close supports. People vary in how private they want to be, how they want to disclose the diagnosis. Another common theme of the counseling is encouraging people to be explicit with their friends and family members about how they want to be treated, because loved ones sometimes feel helpless or feel like they have to give advice or don't know what to say. And so attaching after disclosure a line such as, I don't want you to treat me differently, but I treasure your relationship, and so I just wanted you to know what I was going through, or depending on what someone wants. And a very important area of the psychotherapeutic support that I enjoy doing is to really uncover illness beliefs. People often have very mistaken views of the course of the illness. Their anxiety makes them feel like they're going to be seeing changes day to day or month to month. And usually this illness is very slow. And so uncovering those illness beliefs through discussion with patients, addressing their fears, what their expectations are, affords the opportunity to address those catastrophic fears and reframe things. And that's one of the things I think that is most valuable about the psychotherapy I do with patients, is educating them about Parkinson's and eliciting those catastrophizing beliefs that need to be addressed or chipped away at, if you will. And aging and retirement are very common themes as well. The diagnosis and onset of illness often collides with the time of retirement. And many of my patients have shared with me over the years that they never felt, quote, old until their diagnosis of Parkinson's. And so those are very common themes as well. The standard 6-month follow-up with movement disorder neurologists certainly can make sense from a motor symptom progression standpoint, but generally, there's just so much missed opportunity for support and education, especially in the early phases or in later phases. And so that's where counseling really can be helpful as an additional area of support. Another additional theme that is extremely common in the counseling is issues of identity. We certainly don't want individuals to collapse their identity to that of Parkinson's disease, but also it's important, I feel, to identify rigid dichotomous internal conceptions, such as sick versus well, strong versus weak, and to address those rigid dichotomous conceptions, play with them, challenge some of those oversimplifications because they impact coping and acceptance. The impact of the illness on relationships is another great area of support. Caregiver support is also important, but you know, there's so many important areas for us to focus on. Making meaning of the illness as a opportunity to reflect on what's most important can really make a big difference in coping. And also another common theme is pushing through anxiety because of the tendency to want to avoid things, either due to social anxiety, which we'll talk a little bit about, or other forms of anxiety. So next, we're going to focus on the super important topic of depression in Parkinson's. So first, I just want to begin with some general points and principles. Depression is very common in Parkinson's. There are many different studies that document this. Perhaps about 40 to 50% of people with Parkinson's, depending on the population, have depression. And about half of those have what we might call major depression, and another half have what we might call subsyndromal. It doesn't meet criteria for a clinical major depression, but still there are enough symptoms that it can affect quality of life. And the very important thing that we always emphasize is many studies across different cultures have shown that depression is the #1 predictor of health-related quality of life in Parkinson's. And that's one reason that we'll encourage people to consider treatment, even if their primary outcome measure that they want to focus on is their motor symptoms. The amplification of motor symptoms by emotional symptoms like depression is very common. And so depression is the #1 predictor of quality of life. So we look for it, we treat it when we can. And another general conclusion of the literature and clinical experience is that, of course, depression has complex etiologies. There are psychological reactions to the illness. There are biological factors. There are many different role changes that go along with the diagnosis. It used to be, when I entered this field about 20 years ago, that clinicians would kind of dismiss depression as an understandable psychological reaction. But now it's very clearly understood as part of the illness process. And another really important thing that underlines this awareness of depression as part of the illness process is that the depression often precedes the onset of motor symptoms. Many patients will, in retrospect, identify that there had been a brewing, what we call prodrome. It can be even 3 to 5 years of changes in motivation or mood or enjoyment before the diagnosis. So we know that many patients have depression at the onset of their illness that is not just a psychological reaction. We see it as part of the illness, the biological vulnerability to depression and Parkinson's. Not everyone gets depression, can be part of the illness. Okay. I hope the Wi-Fi is working well. I'm seeing that there's a problem there, but okay. So now we're going to go through all the symptoms of depression, as it's a syndrome with many possible symptoms. So these are the 9 symptoms in the diagnostic manual for depression in the DSM-5 for psychiatry. And it's just important to go through them to show you that depressed mood is only one of the 9. Patients can have diminished interest or pleasure in activities, change in appetite or weight, insomnia or excessive sleepiness, agitation, fatigue, worthlessness, feelings of worthlessness or excessive guilt, decreased concentration, thoughts of death or suicide. To get a diagnosis of major depression, you need 5 out of the 9. But if patients have just a few of them, and you generally need to have the depressed mood or decreased interest to have a full clinical diagnosis, it's still worth treating. But when you look at these symptoms, one might say, well, the change in appetite could just be due to the illness, or the sleep problems can just be due to the illness, not the depression, or fatigue can just be due to the illness. But experts agree that we should not dismiss any of those physical symptoms that are common in Parkinson's, not related to depression, because they can be amplified by depression. So you count them when you're assessing for depression. When to medications, we're going to cover on. So the severity of the depression, of course, influences one's decision to treat with medication as opposed to just counseling or exercise or other non-medication approaches. The 9 symptoms of the 9 before is going to influence one's decision to treat. I already talked about the importance of an inclusive approach to diagnosis and not ignoring any of the somatic symptoms. But the lack of adequate response to psychotherapy might be an additional reason to consider medications, and some patients prefer that. So fortunately, when I first started this working in this field, there were really very little studies to guide our treatment decisions with medications. But over the last 2 decades, there have been a number of studies, though small in their number, to demonstrate efficacy of antidepressants. So when one is trying to choose an antidepressant for treatment of depression and Parkinson's, we're certainly going to look at the evidence base in the literature for Parkinson's, and also the evidence base in general psychiatric or general populations can be useful. You're not going to ignore a patient's individual past history of response to meds. You really have to look at drug interactions and safety concerns, comorbid symptoms. If someone's losing weight, you don't want to give them medication that might worsen that, and vice versa. You might consider a medication that could facilitate increasing their appetite. Fatigue or blood pressure changes would influence your decision as well. And medical comorbidities like diabetes or high blood pressure are going to influence your decision. So I'm not going to go into depth about all of the many different medications that can be considered for treatment of depression and Parkinson's. We'll get to some of those probably in the questions. But just I wanted to emphasize the principles of the types of things that can influence a clinician's decision on which medication. The next topic I'm going to talk about is anxiety in Parkinson's, which commonly co-occurs with depression for many, many people with Parkinson's. So one key I want to emphasize, and I mentioned this a little bit more earlier with respect to depression, is that anxiety is a major amplifier of motor symptoms. And this is something that most people with Parkinson's can agree with if they've experienced anxiety, which many, many have. And so we often emphasize wanting to treat the anxiety with psychotherapeutic approaches, mindfulness, relaxation therapy, medications, because sometimes that allows for less amplification of the physical symptoms. Anxiety in Parkinson's is really complex, and there are many different types that we'll talk about on the next slide. So many, many people with Parkinson's share with me that they have a new vulnerability to anticipatory dread, sometimes even weeks and weeks before an event. Will I be okay? Worrying about the logistics, to look at things like they used to. And yet once they show up, often they enjoy it more than they expected. General worry is also common. Social anxiety, self-consciousness, feeling very vulnerable to others watching their symptoms is another form of anxiety that many people can have. And anxiety and depression, as I mentioned, is common, very common for the mix. It's critical to assess when someone has anxiety, though, whether that's confined to a wearing off period. Many patients will tell me, oh, I feel so anxious, doctor. And I'll ask them, well, let's go through your day. And they say, well, I feel great in the morning. And then at 3 o'clock, I have a sudden surge of anxiety. And then I find out that they take their levodopa dose at 2:45 or 3 o'clock. And their anxiety is confined to a wearing off period. You're going to treat that differently than if the anxiety is across motor states. So that's a very important principle I want to emphasize. So the next topic I want to go into a little bit more is this anticipatory anxiety, what I call the reward prediction error. Dopamine is the currency of reward in the brain. And as I said, many people will report to me that they can't look forward to things as much in advance. They're so consumed by worrying about the journey and the logistics and will I be okay, that they're tempted to not go. And I always emphasize them by reviewing their experiences of pushing through that. And when they show up, that they should live by the mantra, don't listen to your prediction of reward or whether you feel like doing something. If you've enjoyed something in the past, show up. You can always leave early, but you'll almost always enjoy activities more once you show up to them, if they were activities that you enjoyed in the past. And that is a very useful principle for pushing through the anticipatory anxiety. It's often harder to treat the anticipatory anxiety than other types of anxiety, but this behavioral approach is important. The next topic I'm going to address is apathy in Parkinson's. So a definition. Apathy is a state of diminished motivation accompanied by a decrease in goal-directed behavior, reduced goal-directed cognition, and decreased emotional responsiveness or engagement. It's an auto-activation deficit. You can think of it, and I use this metaphor, as a spark plug problem. Once started, many can engage and do well, but self-initiation just doesn't occur easily. And there's a lot of opportunities to educate patients and loved ones about apathy. And on the next slide, I'm just going to emphasize the complex interaction between apathy and depression. Changes in motivation are absolutely common in depression. And so you can have depression and apathy overlap, but studies have shown and clinical experience has demonstrated that people can have pure apathy in Parkinson's. So some principles of treatment are that you always want to treat the coexisting depression and see kind of what remains. Apathy can exist independently of depression, and it's often associated with executive dysfunction, multitasking difficulty, or cognitive symptoms in that realm. And so what about the treatment of apathy? How is it treated? We're going to focus on that next. So a very important principle is to first rule out exacerbating factors. Sometimes people will say to me, "Oh, my husband is so apathetic," and I'll think, "Well, gosh, when I saw him a few weeks ago, he seemed fine." And then you'll get a sense of the time course, and it's a sudden change and disengagement. When that occurs, we always want to rule out exacerbating factors: a urinary tract infection, a fall with a subdural hematoma or brain bruise recently, or some other hidden infection like a brewing pneumonia. If there's a sudden onset of changes in motivation or apathy, that's very different than a very slowly evolving vulnerability. So you always want to rule out delirium, which is the confusional state from an acute medical illness with fluctuations in alertness and lucidity that's due to medical causes. You want to rule that out. You also want to assess for depression, because if it's present, treating that is going to be very helpful. Look for fatigue and turn off my camera. I don't think I can do that. There's a problem with the connection. I'm so sorry about that. Okay. Let's see. Yeah. So now you can't see me, but we'll see if that works better for the connection. I'm so sorry about any connection issues. I got a very powerful new Wi-Fi browser in my office, but it's on 88th Street in Manhattan, where there are lots of big buildings and things bounce off. And so hopefully that's working better for you, and I can get some feedback in a few minutes. Okay, so after ruling out the depression, medical causes of delirium, we also want to look for fatigue. And because that, of course, influences people's willingness to do things. Medication side effects or withdrawal. Sometimes patients have told me they suddenly have stopped a medication recently, and then they had a dramatic increase in their lack of motivation. So if, say, a dopamine agonist, pramipexole or ropinirole, was suddenly discontinued, and then there's new onset of apathy or flatness of emotion, that's going to be a very different thing. But looking at the environment and opportunities for reward are important too. If people are in a diminished environment, and COVID was awful this way, where there are lack of opportunities for reward or engagement, that can be a very common exacerbator of apathy. And so it implies that you need to make sure that the environment is enriched and there are opportunities for reward. Continuing on with the next slide, I already emphasized treating depression, and sometimes energizing antidepressants may be a better choice if there's a lot of comorbid depression. Rewarding activity is also critical. Sometimes people expect a medication is going to just lift their apathy, but if there are no opportunities for energizing engagement and things of interest or social connection, the flatness or apathy may not respond as much. And another important principle of treatment is to treat coexisting cognitive symptoms or executive dysfunction, because, as I mentioned earlier, that's commonly comorbid with apathy. And there are even some studies in Parkinson's that have shown that medications such as rivastigmine, which is a cognitive medicine, that medicine has been shown independent of cognitive symptoms or dementia to help with apathy. And so it's a common trick in the medication approach for apathy for some people with Parkinson's. Treating the fatigue and sleep problems I already mentioned, and I already alluded to the environmental enrichment. So the next topic I want to address is hallucinations and psychosis. So to go through this relatively quickly, psychosis is a collection of symptoms in which thoughts and perceptions have there's some loss of contact with reality, and it's significant enough to affect functioning, and it generally involves the experience of hallucinations, delusions, or both. Hallucinations are images that are perceived and there's no basis in reality to support them. Delusions are a milder form where individuals say looks plant, perceives it as an animal or a small child. Visual are the most common psychotic symptom in Parkinson's. And prevalence varies depending on the sample. It can be challenging to treat. It's so important through the medications and to ensure that they're not contributing, because the number of medications used for symptoms in Parkinson's can exacerbate hallucinations. And the hallucinations and psychosis often are comorbid with a lot of other symptoms, such as depression, impulse control problems. So, as I'm going to emphasize on the following slide, treatment of psychosis should, in part, I feel, depend on the type of psychosis. And so this slide highlights 4 different ways to divide. I'm a splitter rather than a lumper when it comes to this topic in Parkinson's, because I find influences better treatment. Simple visual hallucinations without delusions, paranoia, thinking someone's out to get you, or someone is stealing from you. Simple visual hallucinations, say seeing a child in the room, or seeing a dog, or something else outside the window, that certainly needs to be treated differently. And actually, sometimes cholinesterase inhibitors, cognitive enhancer medications like rivastigmine, may work very well for that, or adjustments in the Parkinson's meds, and you don't need to give an antipsychotic medication. Drug-induced delirium is, as I mentioned before, going to be treated differently as well. You're going to find the cause of the infection, or the cause of the electrolyte imbalance, or the medical cause that is the etiology, and you're going to treat that rather than throw psychiatric medications at the symptoms if it's a delirium. Paranoid delusions often respond better to antipsychotics than to the cholinesterase inhibitors. And on the right, you can see that there are 3 antipsychotic medications that are used in the Parkinson's world that do not exacerbate Parkinson's motor symptoms. Pimavanserin is approved for psychosis in Parkinson's by the FDA. Clozapine is by far the most efficacious, but has a fair bit of side effects and requires some blood monitoring, as we can talk about later. And quetiapine, or Seroquel, is still frequently used, although there are some studies that have failed to show its efficacy. So in general, as we talked about before, you want to look for secondary causes. It's critical to review all the medications that the individual's taking. I've had patients sometimes tell me that they were taking over-the-counter Benadryl or Tylenol PM for sleep, and that can cause hallucinations. So really being conscientious about going through meds is important. And the next topic I'm going to address is impulse control problems. So in this slide, there are 2 pictures. There's an image of someone shopping, and there's an image of a casino and gambling. Those are 2 of the commonly described big 4, if you will. Binge eating and hypersexuality are other areas of impulse control disorders that can be seen in Parkinson's. Dan Weintraub and then other researchers demonstrated that the risk of impulse control disorders is particularly increased by the dopamine agonist class of medications. Pramipexole, ropinirole, and rotigotine are 3 of the dopamine agonists that are commonly used nowadays. Everyone is vulnerable to these symptoms, but there's an increased risk of impulse control disorders in individuals on those medications. That can contribute, though. But other behaviors can be affected as well. People can sometimes get overabsorbed in hobbies, such as playing bridge all day long, or searching on their phone, and family members are saying, hello, what about me? You know, overabsorption in general to extreme degrees can be a mild form of this vulnerability. Risk factors in the literature show that younger individuals with Parkinson's, younger onset Parkinson's may be at higher risk, longer duration of medicine treatment with the dopamine agonists, and a history of substance use vulnerability. His smoking, family history of addictive behaviors, or personal history of addictive behaviors, sex, all of these are risk factors. And so we're going to talk next about the extremely devastating problem. First, again, look at the medications. The dopamine agonists often reduced or discontinued It's extremely critical to follow people closely because people can sometimes have what's called agonist withdrawal syndrome. And we have time to talk about that in the questions. They can have a mood crash if they go down on that and too quickly. And patients will often report to their doctors that they're off or they're stiff, but it's essential for them to be examined during those medication adjustments in person, ideally, because often they feel stiff, but they're not actually rigid. It's more of an emotional off that is dramatic. And we don't want to do phone management of increasing meds without an examination when someone with impulse control disorder is going through medication reductions. And other medications for Parkinson's, saving levodopa for last, can also remit or improve the impulse control disorders. But sometimes patients with Parkinson's, individuals with Parkinson's, can't tolerate the motor worsening. And so you have to find some type of antidote. And getting good sleep is helpful. If individuals have a manic-like presentation, clozapine, there have been some case reports from our group and 2 other groups that have found that actually can remit impulse control disorders if you can't reduce the meds enough. It may be a bit of an antidote. Behavioral approaches of going to Gamblers Anonymous, Sex Addicts Anonymous, Overeaters Anonymous, and 12-step programs are generally inadequate by themselves. They may be useful for relapse prevention, but it's naive to expect that this biologically fueled vulnerability is just going to be able to adequately be treated by those approaches. And standard of care is to involve the medical side as well as those 12-step type programs. So let's bring Dr. Gilbert back, and I'm eager to take your questions on these topics that I've begun to talk about. Again, I'm sorry about some of the sound difficulties. Hopefully that will.
Yeah, so thank you so much, Mark, for that great information. Obviously, there were some technical issues, so we're going to keep Dr. Gross off camera, but we are going to ask him the questions, and hopefully we'll be able to hear the answers as clearly as possible. So for our first question, and this is something that I get asked about all the time, in terms of treatments of depression in Parkinson's disease, are there specific antidepressants that work best in Parkinson's disease as opposed to major depression in the general population? What is the go-to antidepressant that you use?
Yes, a very good question. So it depends on the individual's cluster of symptoms. There are a handful of medications that have had studies demonstrating their efficacy in Parkinson's, which is useful, but most of us as clinicians believe that many other antidepressants in the same families may be efficacious. But just to mention a few of the ones that have been demonstrated to be efficacious, venlafaxine, nortriptyline, dizipramine, paroxetine, citalopram are among those. But very commonly, individuals coming to see me will be losing weight or having difficulty sleeping. And so many savvy clinicians in the field will use other medications that haven't been studied very much in Parkinson's and see benefits like mirtazapine or Remeron for a patient who can't sleep, is losing weight, has a lot of nausea, and is depressed. So there are lots and lots of options. And just because something's been demonstrated efficacious in a study, there may be safer, easier to tolerate medications such as escitalopram or Lexapro that could be reasonably tried for 6 weeks. And if it doesn't work, then you go to something else. Lots of options.
So I guess that's the major take-home point, is that it is a treatable part of Parkinson's for most people. And so very important to speak with your doctor about it. So that actually brings us to a question that Alan asked, which is, I'm 76, I'm retired, I experienced depression prior to my Parkinson's diagnosis, and he has been told that he has treatment-resistant depression. So all those options potentially were tried, and he's been told that this is treatment resistant. What do you do at that point?
Yes, so it's very complicated. There are many people who don't have the home run on the first choice. And to find someone as treatment-resistant depression, depending on the definition, sometimes just means that 3 different medications or 3 treatments haven't worked. Often combination therapy of different medications together can be efficacious for individuals who not respond to monotherapy or individual medications. There are also other treatments for depression, such as transcranial magnetic stimulation or electroconvulsive therapy that can be quite efficacious. ECT or electroconvulsive therapy is actually very efficacious for depression in Parkinson's and the motor symptoms, but people often have misconceptions. You have to educate people about that, and you usually go to that unless you've tried many different combinations. But seeing a psychiatrist or psychopharmacologist who has treated many people with depression, there are usually many other options that can be tried, but not everyone can be treated fully in the way we wish. The home runs can, be great, but some people you need to keep working.
Excellent. Thank you so much. We have a question which I think can be generalized, which is that many of my patients' partners ask how to push medications when the person with Parkinson's is resistant. So in the realm of mental health issues, you need to have buy-in from the person with the mental health issues to get treatment. How do you deal with that portion of it?
Yeah, so it's very, very tricky. For the individuals with Parkinson's who don't have cognitive symptoms and just refuse the meds, but not because they don't understand why they're being offered, that's a unique situation. You explore the resistance, since you spend a lot of time trying to find out what are the symptoms that bother that individual. Sometimes you can align a decision to treat a symptom that is a priority with something that could also help mood, but you want to find out, well, what's bothering the individual with Parkinson's, and you want to build that alliance, build that relationship, address misconceptions about medications, and find some target symptom that the individual is motivated to treat. Sometimes for patients who have more advanced Parkinson's and have cognitive symptoms, there can be transient periods where they don't understand why they're getting the meds, or they're angry and irritated, and they express their irritation at medication refusal, and that's tricky. And usually you take a break, you walk away, you revisit later on, and that's a dilemma to share with the neurologist, and it's tricky, but it's usually variable and spotty and not consistent.
All right, thank you so much. We have a question about delusions. So if delusions are happening, what is the first thing to do? Do you start with changing the Parkinson medications, or do you start with another approach?
So I didn't spend a lot of time because I saw that I wanted to save time for questions. But if the delusions are of a paranoid nature, and the individual is good cognitively, you often absolutely first want to work with a neurologist to reduce medications that may be compounding that problem. Find out if the individual is sleeping at night, because if they're dosing with Parkinson's medication for 20 hours, if you can get them a deep, deep sleep and kind of clear the drain of too much dopamine, if you will, the delusions can improve without having to add additional medication to treat them specifically. But very much going through the hierarchy of medications, saving the levodopa for last, and reducing dopamine agonists or the other classes of medications, the inhibitors. It involves a discussion with the neurologist. I often ask my neurology colleagues, can I reduce this medicine, which may be contributing some? But then if that doesn't work sufficiently, you go to the pimavanserin, clozapine, and some still use quetiapine, and you treat it that way.
Okay, fantastic. We have a question from David, which I'm going to tie into another question. So David's discussing anxiety. What alternatives are there to benzodiazepines to treat anxiety? And there's also this concern that you hear about from people that maybe benzodiazepines contribute to cognitive issues. Can you address using benzodiazepines in Parkinson's disease? Are there alternatives? Is this something that we use often, etc.?
Sure. So first-line treatment for anxiety in general often involves an antidepressant. It's safe. It can work for many different types of anxiety. The SSRI class citalopram, sertraline, for example, can work quite well for social anxiety, panic. And so trying one of those medications, which are very safe first, it takes 6 weeks for them to kick in, is a very reasonable standard of care approach. But when it comes to that class of medications called benzodiazepine, which includes Xanax, Valium, Klonopin, there's definitely controversy. There are some militant geriatric psychiatrists who believe we should never give those to anyone over 65. They can have balance impact. They can have clouding effect on some individuals, especially if they have cognitive symptoms. But the controversy comes from some association studies that have shown that elderly individuals given those medications are more likely to get dementia. But that is not a causal, those studies do not prove causality. If you select in a population of people over 65, individuals with high, hard to treat anxiety, many of those individuals have a brewing neurological illness. It could be Alzheimer's, it could be vascular dementia, it could be Parkinson's and something else. And so there's what's called the protopathic bias. So I'm in the camp, as most of my movement disorder colleagues are, that you don't need to be militantly avoiding all these meds. We find them useful for other symptoms of movement disorders like dystonia, clonazepam is useful for acting out dreams or REM sleep behavior disorder. You just want to be very careful. And if someone is vulnerable, you want to monitor whether there are cognitive effects. You want to keep the dose low. But reducing suffering is our goal, and sometimes the other meds are insufficient. Another example is the wearing off panic that individuals have. Ideally, the neurologist adjusts treatments to fill in the valleys, but sometimes a tiny dose of a benzodiazepine like alprazolam or lorazepam can be helpful in reducing that suffering. So I'm definitely in the camp that use them with caution, but I don't believe they biologically directly cause dementia. But certainly, if someone is already having significant cognitive problems, it could be clouded on it, and you want to monitor the pros versus the cons.
Excellent, thank you. That was very helpful. We have a question from Karen. We really didn't discuss cognition at all, which of course can be thought of as a mental health issue. So is cognition or dementia a separate issue? Is dementia part and parcel of some of the things you're talking about? How does the cognitive piece, you've mentioned it a few times, how does that feed into some of these symptoms that you're talking about?
Yes. So because there's so many topics to talk about, and because you've had other speakers on specifically on cognition and dementia, I didn't speak about it a lot, but certain symptoms are absolutely correlated with cognitive changes. Apathy, not always, but can be. The delusional misidentification syndromes, which I skipped over a little bit, but when people misperceive a loved one as someone else, or they think that they're not at home, but they're at home, and their place or person recognition circuitry, if you will, in the back of their brain is not working, those types of symptoms called delusional misidentification symptoms are often correlated with cognitive changes in dementia. So when an individual has a lot of non-motor symptoms, autonomic changes, anxiety, depression, apathy, all at once, being very conscientious in assessing for cognitive symptoms is really important, because it often is comorbid with or goes along with a lot of different behavioral symptoms when there's a lot at once. So you want to know if that's present, because you might give a cognitive enhancer medication like rivastigmine, and sometimes that can help anxiety, that can help apathy, that can help engagement and alertness. So I have a low threshold to assess for cognitive symptoms, and you often need collateral input from a loved one to be able to do that well, in addition to some pen and paper tests.
Great, thank you. We have a question from Freddie 4. What techniques can you recommend for family members and caretakers struggling with denial related to their diagnosis?
Yes, so a very interesting topic to a consult psychiatrist. We always first want to assess, is there really denial going on, or is the individual with Parkinson's having a different psychological reaction than the spouse or partner? Because sometimes individuals are not really in denial. They're aware of it, but they're just not having the emotional responses that others would expect them to have. So a really detailed discussion of what they believe and how they're coping with it. There are definitely many individuals who disavow the illness and don't adjust to risk reduction strategies if their balance is off or other things. And that's tricky. You definitely want to involve counseling, build a good rapport with them. Pushing through denial or confronting people about denial is often not effective, because if anxiety is one of the main reasons motivating the denial, amping it up often doesn't necessarily lead to insight, but it depends. Sometimes that can work. So it's a tricky thing, but exploring it in depth is essentially critical, because there are different approaches depending on the flavor. Sometimes people just don't understand it enough. It's complicated.
Great. Yeah, that makes a lot of sense. That was a lot of good insights there. We have a great question from Mia. This comes up a lot. You mentioned the impulse control disorders, hypersexuality being one of them. So if you have an individual who is demonstrating hypersexuality combined with dementia, how do you approach that? It could be very, very tricky and challenging.
Yes. So same general principles. Look at all the medications, because it very well may be, if the neurologist is not as aware of the hypersexuality, it's uncomfortable for us to talk about sex, and we don't always, as clinicians, ask about it enough. Medication reductions may still be able to be made. If that's not the case, clozapine sometimes can be quite efficacious. Antidepressants sometimes can help with hypersexuality because they can affect libido. And so sometimes that's a trick that is used in patients with dementia who are hypersexual, looking for the contexts of that behavior, time of day, whether it's related to buildup of medications. There are a number of different approaches. And at the most extreme, there can, which we almost never use, there can be kind of hormonal approaches, but it depends on the nature of the excess sexual behavior.
Okay, great. Thank you so much. So we are amazingly out of time. Always these sessions go by so quickly with so much great input from our audience. So thank you so much. So we have time for one last question, and this is a question from Doreen. So you mentioned a lot of interaction that's necessary between a neurologist and a psychiatrist. If a psychiatrist wants to change medications, etc., and how these different symptoms interact. What is the best way of coordinating your doctors? So it could be that you, Dr. Groves, have way of reaching out to neurologists, but in general, it can be very tricky to coordinate doctors. What are your suggestions about getting everyone to be on the same page?
Yes. So I often volunteer to kind of speak with the neurologist. I mostly see people who I have already relationships with. So that's, of course, a unique situation. But it is hard to get doctors to talk with one another, but it makes such a difference. Nowadays, with the electronic records merging between different hospital systems, sometimes doctors can easily send messages to each other through the portals of Epic, for example, or other things like that. Encouraging and the communication and following up on it certainly can be helpful. And care managers sometimes can facilitate that coordination by, in a way, nagging the doctors to talk with one another, but it's super important. Sometimes the patient can be the deliverer, if you will, of the information and pass on the questions on behalf of the busy doctor who may have difficulty in business hours having time to reach the other doctor. But keep pressing it, because it really is important for quality of care. All doctors should know the correct medication list, and it's very important.
Absolutely. Well, thank you so much. We want to thank Dr. Groves for all that fantastic information. I want to thank everyone for participating in today's discussion, for submitting your questions. And if you know somebody who missed today's program, if you joined late or would like to watch again, this recording will be available later, and we will make sure that there are appropriate subtitles so that everything will be much more understandable the second time around. So please go to our YouTube channel and you'll be able to follow anything that you may have missed there as well. So for any additional information and resources, please visit our website at apdaparkinson.org. And there is a ton of information there about Parkinson's, mental health issues, etc. And please join us for the next Dr. Gilbert Hosts, which will take place on May 23rd. We're going to be joined by a special guest, Dr. Claire Sexton of the Alzheimer's Association, and she's going to be addressing the connection between Alzheimer's disease and Parkinson's disease and discuss differences and overlaps between these two diseases. So it should be a very exciting conversation. So please be sure to join us on May 23rd. And be sure to stick around for a few final messages. Before I go, I want to thank you once again for joining us today, and we hope to see you soon on another APDA program. Have a great afternoon.
Hi, I'm Leslie Chambers, President and CEO of the American Parkinson Disease Association. Thank you so much for joining us today on our program. Every day, APDA is committed to providing helpful programs just like this one, as well as a wide variety of support groups, exercise classes, and educational programs to support the Parkinson's disease community. Whether online or in person, APDA is here for you every step of the way. You can find all of our upcoming virtual events on our website at apdaparkinson.org/events. We keep you posted on our social media channels as well, so make sure you follow us there. You can also connect to local resources and events through our nationwide network of chapters and information and referral centers. Remember, we're just a click or a phone call away. If you've enjoyed today's broadcast, I hope you will consider making a donation to help keep programs like this possible. Every gift, large or small, helps APDA support people living with PD through thoughtful programming, reliable resources, groundbreaking research, and more. Please visit apdaparkinson.org/donate today to support our critical work for those with Parkinson's. We are so grateful for your generosity. Thank you.